lecture. Now, without much delay, I invite the second speaker, Dr. Kishor K. The topic is perioperative metabolic hemodynamic and coagulation status monitoring for liver transplant. So, Dr. Kishor K. is a senior consultant, head of the department anesthesia and intensive care, Aster Malabar Institute of Medical Sciences, which is a tertiary care center. So he does major GI surgery, renal transplantation, pediatric surgery, and general surgery. He also covers the surgical intensive care unit, and he is a member of resuscitation committee of the hospital. He is a lead consultant since 2013 for liver transplant. Performed anesthetized more than 300 liver transplants, and he runs also a DNB program which has 4 seats every year and a very good percentage of pass. So I welcome Dr. Kishor.
Thank you. At the outset, let me thank the organizers for asking me to share some aspects of monitoring while doing liver transplantation. You all know that transplant is a major surgical undertaking, and there's a potential for huge fluid shifts and bleeding. So it sort of warrants intense monitoring and organ support to improve the outcome. As cardiovascular events are the most commonest cause of death apart from graft-related issues, you place more emphasis on cardiac vascular monitoring, and of course you need to monitor the coagulation system and some of the metabolic aspect. If you look at the hemodynamics happening during the procedure per se, you can divide into 3 phases. The initial phase, the dissection phase, or the pre-anabatic phase, where the surgery starts till the blood flow to the liver is stopped. So in this phase, mostly bleeding happens. Potential for bleeding is there. Significant fluid shifts happens. There's a drainage of huge amount of ascites. And moreover, when the surgeons are doing this dissection, they tend to obstruct the vena cava by pressure and pull of that area. So again, there's a lot of chance for hemodynamic instability happening during that phase. The second phase, which starts from the stoppage of blood supplies to native liver till the reperfusion of the new liver happens. Again, during these procedures, there's continuing bleeding, continuing coagulopathy producing bleeding. There is cross-clamping of IVG and the portal vein, which produces 50% reduction in cardiac output. Again, chances of hemodynamic instability happening is much more. During the neohepatic phase, that is from the reperfusion, once the new liver starts functioning to the end of surgery. And this itself is marked by the reperfusion happening when you take the clamp off, and there is rapid return of blood from obstructed portal vein and from the new liver, which is acidotic, cool, hyperkalemic. So again, chances of hemodynamic stability is there. So throughout the surgery, there's always a potential for hemodynamic instability happening. Now, how do you go on monitoring these patients as far as cardiovascular status is concerned? You basically have a 5-lead ECG, invasive blood pressure, the central venous pressure, and cardiac output is monitored in these patients. Now, which artery, how many arteries, again, depends on the institutional practices and individual preferences. Red artery is commonly used. One of the concerns or the concerns when you use peripheral arteries that in situations where you use very huge doses of vasopressors and fluid shifts, they may not reflect actually the central pressure. So some units use one femoral artery line and one red artery. Two lines are always preferred, because one line you can always dedicate for sampling, and one line you can have a continuous uninterrupted arterial pressure monitoring throughout the procedure. So either 2 red arteries or 1 red artery or a femoral artery. Now, coming to cardiac output, pulmonary artery catheters has been the gold standard, or is still the gold standard for monitoring cardiac output, the thermodilation technique. But however, the inherent risks associated with this procedure and the risk of using PSC catheters make catheters fallen out of favor, not only in liver transplant but in other cases as well. So we've been looking for minimally invasive or alternative to PSC catheters. That's commonly used nowadays. That's the arterial cardiac output measured based on the arterial form analysis or the arterial contour analysis. This you can do it the simple arterial line. There are very commercially available many devices are available, but these three are the commonly used one: the PICO systems, the LIDCO system, or the flow track Vigilio. The PICO and the LIDCO uses some form of indicator dilution. PICO uses cold saline like in pulmonary artery cathetery, but it is it's less invasive as you use only the arterial line, and the LIDCO uses lithium as an indicator dilution. Flow track Vigilio doesn't use any indicator dilutions, but it has its own proprietary algorithms through which it measures the cardiac output, and then they all calibrate it with the measured cardiac output is calibrated with the arterial shape or the arterial contour. Then they give a continuous cardiac output readings. For the transplant modulation, you have to use a thermistor-tipped femoral artery catheter, and you inject saline to the central line, and the temperature is sensed at the femoral artery. That's why it gets transpulmonary thermodilution. And one of the other aspects of using these type of monitors is you get some good indicators of volume status of the patients, like the intrathoracic bed volume index, a global interstitial volume, and extravascular lung water indexes, and also the pulse pressure variation and the systolic stroke volume variations are also measured while you use this type of non-invasive cardiac output monitors. Now, the question mark is, are the cardiac output measured by these devices accurate or comparable with the one measured by pulmonary artery catheter? Though there were initially reassuring studies, later on studies found out they don't actually correlate well with the cardiac output measured by the pulmonary artery catheter method, especially in situations where liver transplantation, where all these cirrhotic patients are hyperdynamic circulation, low SPR, and when they have vasoactive mediators and massive fluid shift, the measured cardiac output tend to be not accurate. But majority of the centers do use non-invasive or minimally invasive cardiac output monitors. The other aspect in cardiac hemodynamics monitoring is how do you assess the volume status of these patients? Like, we know that the static measures of central venous pressure and pulmonary arteriocclusive pressures are poor predictors of prolapse. It has been found out. Now, it's extremely important that you do your volume resuscitation or volume status approach right, because if we use huge amounts of volume in this patient, the graft will get congested. The drainage from the new liver graft will be compromised, and you can have a graft dysfunction. And if you use lesser amount of fluids, then patient may end up in AKI or ATN, etc. It's going to happen. So you need to give the right amount of fluids. As I mentioned earlier, the dynamic indices of the stroke volume variation and pulse pressure variations are changes in the phases of respiration. These are measured by these minimally invasive cardiac output monitors, apart from the other global interstitial volume index, etc. So, if you have an exaggerated changes in these stroke volume variations and pulse pressure, they are found to be very good indicators of fluid responsiveness, especially. That's proven many studies that they are good responders of fluid challenge. So if you have a stroke volume variation of more than 10%, then that means that patient is fluid responsive. You need to give more fluid. Now, few conditions you have to these measures has to be accurate. The patient has to be mechanically ventilated. You have to have sort of fixed tidal volume. So these are good minimally invasive options to monitor end-diastolic volume and fluid response. This is the monitors which we use. The flow track Vigilio, as you can see, they give stroke volume, cardiac index, as well as the stroke volume variation. If you put a volume view catheter along with it, you will get the other parameters of extravascular lung lung water index and global end-diastolic volume index. But that's where you need an extra catheter along with this monitor, the femoral artery catheter with thermostat. So, but we generally use these things. And this is the special set of transducer which comes along with this monitor, flow track monitor. The other monitoring device for hemodynamic monitoring is transesophageal echo. That has been increasingly used in liver transplant situations. It gives direct visualization of the preload of both right ventricle as well as the left ventricle, and you get a real-time detection of RWMAs if it is happening. Moreover, it gives good information about the contractility, and in case of any case of air embolism or thrombus happening, that also can be easily detected. However, there is some limitations because you need significant training and expertise to use TE, and some amount of cost is also there. But this is very important. You need good training and expertise to correctly position and correctly interpret the values. The other concern is the presence of esophageal varices and bleeding, which can make things from bad to worse. So grade 3 or 4 varices is a contraindication. It has been used in patients with grade 1 and 2, but it's always with a caution. So that's with status of TE. This is some form of monitoring. You can escalate the monitoring system based on the patient status. Well, liver transplant does have a lot of fluid shifts, blood loss, sudden loss in preloads, and some blunted response to catecholic. So it makes vitally important that you do intense monitoring of the system to improve the outcome. Well, I just briefly want to see about a radial artery and CVC. You monitor diabetic indices, and in patients, if it's much more riskier, you could use transmural and endovascular waters. A transesophageal echo increasingly being used. Pulmonary artery catheter is always a question mark. You could reserve it for patients with, if you want to monitor portopulmonary hypertension, you could use pulmonary catheters. And in such cases, yes. Coming to metabolic aspects, hugely metabolic changes also happen during the procedures, and glycemic control is always important because that may affect the outcome. Hyperglycemia as well as hypoglycemia happens. Hypoglycemia is an ominous sign, especially in the post-op after the new graft has been put, because if patient has persistent glomerulus, that means there is some amount of graft dysfunction happening. So hourly monitoring sugars is important. Electrolytes, again, electrolyte imbalances are quite common. Most of the patients with cirrhotic patients, they have hyponatremia. You sort of accept the case with sodium levels of 124 or 5 or above. You have to be extremely cautious in such borderline cases because you don't want the sodium to get overcorrected and patient developing central pondyl myelinosis. So you need such patients, you need to choose the IV fluids and diluent solutions appropriately, because as we use a lot of infusions, a lot of drugs are given in infusion, you use a lot of diluent solutions. So make sure that your IV fluids and diluent solutions you use are absolutely correct. It doesn't want sodium to get overcorrected. Potassium also, hypokalemia, and for obvious reasons happens. Hypokalemia is also quite common because we use a lot of blood transfusions. Following reperfusion, you can have hypopenia. Some amount of AKI also sets in the liver transplant surgery because of the hypotension and other issues. And if you have a long warm ischemia time, again, hypokalemia is important. So you monitor and correct it accordingly, all these electrolyte imbalances. Acidosis is another metabolic derangement which happens. Mostly metabolic is due to decreased lactate clearance. Lactates accumulate because of hypotension following reperfusion. Again, liver manipulations, and there are situations where there is no liver at all in the patient till the new liver comes in. So plasma lactate concentration is always monitored serially, and you do serial ABG measurements which gives you information about lactates as well as the electrolytes and sugar. So that is one thing we do quite regularly. You need to continue this introp as well as post-op because lactate is a marker of liver function. So if there is inadequate liver lactate clearance, that means the graft is not functioning properly. If the lactate is coming down, then we are rest assured, we know that graft is functioning. So monitoring of metabolic disturbances are vitally important, and it's quite integral to interop management. This is some sort of, we always, this just show the, how we go on recording these values and in perhaps hourly or 2 hourly. The other important aspect of monitoring is the coagulation monitoring. You know that these patients are coagulated. Most of the patients are coagulated, patients are CLD. Only thing is that coagulation is sort of rebalanced. Even if the patients have an INR of 3 and platelet of 50,000, they don't generally bleed. But during surgery, bleeding remains a major challenge. So you need to assess and treat bleeding and coagulability appropriately. It becomes very important, because if you use more blood, more transfusion means the outcome may be, the outcome is more, morbidity is more. So you need to try to reduce the amount of blood you use and the products you use. Traditionally, we've been using standard laboratory tests like prothrombin time, INR, APTT, the platelet count, and fibrin concentration. But do they reflect actually, do they tell us that any particular patient bleeds? Well, another thing is the turnaround time is more, and the question mark is always asked about their reliability. And many of these studies which looks at the usefulness of these tests, whether they predict bleeding, has found to be there is no good evidence to guide hemostatic therapy based on standard laboratory tests. So we actually use, like Sham mentioned earlier about the viscoelastic testing, the point of care viscoelastic coagulation testing, because unlike the other tests, they look at the coagulation as a whole process, look at the clotting as a whole process. Commonly used ones are the thromboelastography, the TEG, or the rotational thromboelastometry, the ROTAM. And they have been found in many studies that they're superior in identifying coagulopathy, and subsequently they reduce the amount of products or the blood transfused. Both these tests actually gives out of a graph which you look at the clot initiation, the clot kinetics, the clot strength, as well as the clot stability. And they both are fibrinogen sensitive, assays, so that if there is increased fibrolysis, the graph will become rat-tailing, gives a graph tail appearance. These both are essentially similar, but it looks at it through different mechanisms, and their nomenclature for their test results are a little bit different, but essentially they give the same information. The MCF gives the clot firmness, this is clot initiation process, and this is the nomenclature. There's some pictures about the ROTAM picture. Now, there is no such algorithms, but basically if these are the normal values, if the MCF, there are much different reagents with ROTAM. You have an extum, you have an FIPTUM or an aptum reagents. These are normal values. If both extum and FIPTUM are less or more than less than these values, then obviously you require some amount of fibrinogen transfer, cryopreservation, or fibrinogen concentration, fibrin transfer. If the extum is less than 40, but the FIPTUM is more than 9%, that means the fibrinogen component is okay. Only the platelet component, which gives the clot stability, is the culprit. So you need to platelet transfusion. If extum is more than 80 seconds, then probably you need FFP or prothrombin concentrates. Sorry. And if there is excessive lysis, you give tranexamic acid. Again, as I said, you can't purely based on guide transfusion, purely based on the lab results or the TEG or ROTAM results. You need to make close-ups, communicate with the surgical team closely. If they say, even if the tests are normal, if they say there's bleeding, probably you may have to use blood and this thing. It's pretty, because the status of coagulation is quite dynamic, it's very much difficult to make algorithms based on test runs alone. You need to close up the surgical field, suctions, and communicate with the surgical team. This is again a picture of how the ROTAM works, ROTAM picture, different tests. Now to conclude, liver transplant is a complex surgery. You get a lot of fluid shifts, you get a lot of bleeding, you get a lot of metabolic derangement. So it becomes vitally important that you extensively monitor. Now, to what extent and which type of monitor to choose is based on the individual and the institution. Basically, but you need to do, you don't fix by one and only right one monitor, but you integrate monitoring based on patient clinical status. And another important aspect is that you continue the monitoring post-op and so that you improve the outcome. This is just to show the picture of we do this is there's again PPV and SVV coming in temperature, then we do entropy monitoring along with the other the minimally invasive cardiac as well. Thank you very much for the place in listening.